Thank you very much. I'm really, very glad you've stayed. Jane's given me the death slot. But I'm in a room full of some of my heroes, so it's a fantastic pleasure to be here. One thing that has struck me over and over again in the course of the meeting is that we have to remember that surgery is only an event in the course of a disease, and we mustn't ever forget that it's part of that continuum. I've got some disclosures, which I'll show you on the screen. Unlike the current Chief Medical Officer of Sloan Kettering, who was fired today because he didn't put up his disclosures, which were amounted to $1.5 million a year. But I am a cardiac surgeon, so I'm always right. And so whatever I say from now on, you can completely accept. There are three reasons why I was very glad that Jane asked me to talk today. The first is that I work in a discipline where I basically never see the same thing twice, or at least not much of the same thing twice. It's heterogeneous and small volumes of things in a specialist hospital. In fact, I've been involved in the first in man or first few in man procedures in at least 10 times. That's led me to notice that our literature is full of optimistic first reports, but absent or missing second reports, the second wave of surgery. And the third reason, and this is perhaps the main theme of my talk, is about lies. And it may come as a surprise to you that some surgeons tell lies. And we have to acknowledge that. Now, Kim Sirota has done a lot of work on liars. Almost 50% of lies are told by only 5% of the population. And what that amounts to is, another way of saying that is most reported lies are told by a few prolific liars. I know of no presidents, for example, who will be categorized in that way. There's no difference, however, between the UK and the USA in the distribution of prolific lying. What is interesting is that it's more common in young males and those of higher occupational status. So those of you in that category should leave now and leave it to the women. And you'll all be aware of these famous cases of people whose lies were exposed, and they were hugely shaming for the medical profession. They're very, very big cases. And probably those who aren't aware of those will definitely be aware of this chap, who lied in all sorts of ways, some fraudulently, but he would perhaps take the view this week that that's not maybe such a bad thing, since he appears now to be going out with Elle Macpherson. Liz King looked at the surgical literature over the last 25 years. 184 papers have been retracted in various disciplines in all sorts of countries across the world. That is a lot of stuff being pulled out of the literature. And the reasons it's pulled out largely relate to data, either duplicated, falsified, or wrong, and a small percentage frank plagiarism nicked from other people's work. Now, they were found out, but it seems to me that it's quite likely that there's some others just below the surface who probably weren't. And I want to ask the question, what would you do if the liar was someone you knew? And how would you behave? What would happen to you? Well, it's happened to me. Many of you will know about the story, but I'm just going to do a tiny bit about it. This is Claudia Castillo, a lovely Spanish lady whose junction between the trachea and the left main bronchus required replacement. And this paper appeared from various sources, as you can see, with the lead order of Paolo Macchiarini, whose name has come up a couple of times already in this meeting. Paolo had done a lot of basic science with other people across Europe to set up a stem cell-supported tracheal transplant. And it was quite a cool idea. This paper came out, and we had a patient in 2009 who had had multiple tracheal surgeries since he was born, and he needed a new trachea because he was actually dying of trying to bleed out through his trachea, and we couldn't think of another way to do this. And we searched for a technique contacting all the other tracheal surgeons that we knew around the world, and got in touch with Macchiarini and other groups, and finally decided to replace our patient's trachea. It took 3 months of keeping him alive, sedated in an ICU in Bristol, in Belfast, before we were able to do it. We'd been to, I think, a total of 30 ethics committees and clinical approval committees of various sorts in different continents, in different universities, in different countries, sorry, in different universities and in different hospitals. We presented the case clinically to our clinical ethics committee at Great Ormond Street with the parents there. They helped with the presentation. They were fully informed. I think I can say that with hand on heart. What they did know was that this was an experiment. They were part of it, and we had absolutely no idea whether he was going to live, die, or be harmed. In 2010, we did the operation. This is film of it, and it got published, and there was lots of press coverage because it was a world first. And although we had not set up any press coverage, somebody leaked it, and we were inundated with requests. I'm delighted to say that this is just filmed 6 years out. He's now 8 years out. He has normal cilial function in his middle airway. He's leading an almost normal life. He's fully grown, and is on no drugs, no anti-transplant drugs. No idea whether there's anything to do with the stem cells or he's just a lucky boy. Sadly, Macchiarini went away to Karolinska, and he adapted a technique which had been started at UCL, taking a nanotechnology-derived polymer, this holding one up here, which he didn't use. He got one made in Harvard by a Boston company, and got a big grant, we think from Russia largely, and saw a little bit from Sweden, and started peripatetically installing these grafts around Europe, one in North America and throughout Russia. Rumors of bad results spread through the community quite quickly. But I'm delighted with Deborah in the audience to say that what really cracked this story was a brilliant Swedish journalist called Bosse Lindqvist. Bo Lindqvist is a very, very good journalist, the quietest draw out of information from the people around him that you could wish to meet. And he wasn't happy with what he saw and what he read, and he went to the source material in every hospital that he went to, and published a brilliant documentary called Experimenten, which you can still find on the web. But what brought him down, what brought Macchiarini down, wasn't that so much as the fraud case that was brought against him in Italy for private patients, consent issues in Karolinska over the patients in this study, and then perhaps the issues over his data and outcomes, which we all began to doubt, and Bosse Lindqvist exposed. The final story was sex, lies, and I'm glad to say videotape, otherwise there'd be no joke on the slide. And the videotape comes from Bosse Lindqvist. The sex story is wonderful, and you can read about it at great length in last February's Vanity Fair. That's the title of the article on the right. And he made eyes at and was met by some receptivity by the producer of an NBC producer who was a Pulitzer-winning prize documentary maker. He proposed to her, and a wedding was set up later that year. And the rest of the story is basically that he was lying to her. And you can read all of this. It's all in the public domain. Now, he was fired from Karolinska, a combination of all of these issues. But that wasn't enough. They fired the head of surgery. They fired the vice chancellor of the university. The provost resigned, and so did the head of the health service in Sweden. All right? Lies don't pay, but not necessarily for the person involved, because he is now professor of surgery in Kazakhstan. Not surprisingly, there were lots of investigations launched, and anybody who'd ever worked with him became a subject of these investigations, myself and other members of this audience included. There was an enormous loss of credibility in the subject, and it became difficult to get grants and to sustain trials which were already in progress. And maybe that's the right thing, because there's this guy upon which some of the science is based, and suddenly the rug is pulled away from what you believe. We trusted the science that was in the Lancet, that was in the New England Journal, that was in other major journals. Data that had been submitted and reviewed by you or me was out there, and we trusted it. And it turns out to have been lies. We weren't terribly happy. Now, I thought about my 40-odd years in cardiac surgery and looked back at my life and thought, actually, I do feel some shame. This triggered some feeling of shame in my belief in myself and my specialty. Firstly, it was self-evident that we had not used our data very well. Secondly, people who were writing papers or submitting papers were hanging on to it. It sat in a USB stick in the back of your car. It wasn't visible. There was an enormous publication bias in my specialty. Positive papers got published, negative papers didn't. New stuff got published, follow-up papers didn't, until quite late in the course of the disease. And the data associated with the patients, particularly in the second wave, were lost. They were irretrievable, which when you think about the fact that those patients had voluntarily submitted themselves to an innovation is an act of immorality in my view. Now, there are very good reasons for how this has come about. And the first is that we live as clinical academics in the publish or be damned world. Let me explain that further. If we innovate, and that's what this meeting's all been all about, and we've all been talking about publishing, there are currently, when I looked this up last week, over 11,000 active journals in the world. None of us are going to read all those every day. That's a massive amount of stuff. Each journal sends it out to peer review, some of us, and it might get published. Now, in surgery, the more you publish, the higher your pile gets. And that means that you get brownie points. And brownie points are terribly important, and they're based on the impact factor of the journal and the citation index of the paper. You know the definitions. I'm not going to give you those. But in surgery, at least, and I attend enough interviews to see that this is still the case, the number of publications is shorthand for how good you are. I can't get promoted academically, and I certainly can't get a grant without lots of papers with high impact factor journals or a good citation index. Now, in pediatric cardiac surgery or pediatric ENT or something else, you're very unlikely to get into Nature. Your impact factor is bound to be at the lower end of the spectrum, so you're not likely to be top of the list in the big grant-giving bodies unless you're lucky. There's a second problem, and that is the cozy relationship between journals and universities. Now, in 2011, 3 publishers managed 42% of journal articles. Subscriptions accounted for 65% of library costs. The other people who bought the journals were largely drug companies, by the way. Journals market their impact factor, and we soak up that idea quite well. We need the impact factor to get our brownie points. It's how we get promoted. It's actually a cozy cartel, if you think about it in one way or other. They're both mutually dependent as systems. And it's a $7.5 billion industry across the world. Now, that's okay. Publishing is good. We all want to read journals, and we think it's a good way out. But a lot of that information is hidden behind a paywall for other people who might want to read it. I work in a university, so I can get onto my university library for free through MetaLib. I'm sure you all can too. But if I'm a patient wanting to read it, why should I pay $15 to $25 or even $50 to read an article relevant to my disease? I don't think that's right. George Monbiot published an article just yesterday in The Guardian saying exactly the same thing. He wanted to look up something about one of his relatives and found he was being charged, I think, $50 to read it. How right is that? Sorry, let me go back a bit. Now, my specialty has of operating on a child's heart. This is a heart at term. Next one coming in is at 20 weeks, which we're beginning to be able to operate on, fully formed. And there are 3,500 things you can have wrong with your heart when it's born, and 2,500 list of procedures I can do. So it's going to be quite easy for me to find some matrix in the middle of that which allows me to create the Elliott operation. Now, I'm a cardiac surgeon, by definition vain, and so I'm going to give it my name. Lots of operations are eponymous. Now, we've heard a lot about working in teams, and my team and I sit down and think about what we're going to do for this combination of anomalies, how we're going to treat it. And we create this operation, and how we're going to do it becomes a topic of discussion. We get it through our internal processes, and I do the first, say, 10 operations. And I think the outcome is good, and actually it very often is, because you've done such a lot of thinking and discussion in detail about this one procedure. So I send it to the journal, and the journal sends it out for peer review. It's new, it's positive, and attracts readers, and very often those kind of papers get published. Does anybody disagree with that? No, let's start from there then. Okay. But actually what I'm submitting to the journal is a précis. It's a summary. I've got a word limit, which means I can't really tell them about that thinking. No journals, hardly any journals I submit to, ask for something to be posted on the website which tells the secondary people what to do. And it's really easy to bullshit people with some nice diagrams. And if you choose your diagrams well, and you've all been involved in discussing things at your universities where you take the same data and different modes of presentation and fool an intelligent audience quite quickly. The big problem is that when I put this together, this paper, I have created, if you like, a data set about this condition. It's mine. I own it. I designed it. It's unreviewed, usually. I'm going to come back to ideal in a minute, of course. But I've got all sorts of things which make this tricky. I have commitment to my idea. I'm therefore biased. I have a massive conflict of interest because my next 10 years' air miles are going to be dependent on the success of this paper. I have no idea whether my data set was comprehensive or even correct. What gets sent to the journal, as I said, is a précis, a summary of all of that, and it's the data drawn from that data set. But the bottom line of all this is that the raw data stay at home. Very, very few, if any, medical journals ask for the raw data to go with the paper. I'll come back to that again. Now, my 10 patients get out into the literature. You're all highly competitive cardiac surgeons in the audience. You work in competitive institutions. What's going to happen next? You're all going to want to try it. More ops get done elsewhere. Why did people want to do it? Well, they're convinced the operation's right. They read about it. Maybe there's a certain vanity. Why should Elliott get the name for this operation when it would be much better if it was Blaisby's operation? Or maybe it's academic or institutional survival. You have to do new stuff to keep your place. That's less true in the UK than it is in the United States, but it's still true. Very often, and I'll justify this in a minute, worse outcomes occur in that second group of operations because I haven't been able to give all the tricks away. If I send it to the journal, and I would expect it would go for peer review, but actually the journal usually says no because it's negative results and it's not new, so then peer reviewers don't get to see it. Much more importantly than all of that is that the data associated with the patients who've given their consent for an experimental procedure, their data never get published, their data are lost, their data are kept on the USB stick of the surgeon. How right is that? Now, it'd be nice to think that my specialty, which has got quite a good track record of self-audit, of publishing over the years, it's got a lot of things. We've got a lot of eponymous operations that give people fame. Two of them in particular are highly relevant in this context. The arterial switch operation was an operation done for transposition of the great arteries. At the time, we were getting fantastic results with a thing called the Senning procedure. Doesn't really matter what it is, but it worked. And then along came this one, which in theory would be a way better operation because it used the left ventricle to support the circulation. Everybody believed that. The Norwood operation was done for hypoplastic left heart syndrome, for which everybody died. So there wasn't really a potential control group for that. It was death or nothing. This one had a potential control group. So you could have randomized from the first case. In both those publications, small volumes, in the case of the Norwood, 3 patients with a 60% survival, drove copying across the world. And surgeons weighed their cojones by how well they could do the Norwood operation. It became how you tested the hospital and yourself. Hundreds of patients died in the second wave of surgery after both these procedures, and none of their data are publicly available. Now, during that phase, of course, there were massive iterations in the procedure that you've heard about as part of the ideal process. Iteration is what makes us better. But we don't know what they did because it's not available there. There are some retrospective studies that went back and looked at the death rate following these operations, so I know that that's true, but it was way higher than is visible from the literature. There must be a better way, is my argument here. And obviously, I feel peer review is completely at the wrong stage. That's going to challenge some of the things we've been hearing today. This is where you will agree, I think. The peer review of the protocol and the data set before you start collecting data is critical. It's what IDEAL talks about, what it does. That is the stage, to me, of most important time to have peer review. No data, blank data set. Are we collecting the right stuff? Including data definitions so that you can exchange it electronically. Date formats and all of that stuff. Those data sets must be open to review, criticism, and contribution. They've got to have the data definitions. They've got to be securely held. And they've got to be accessible for review. That, I think, is what IDEAL offers. Is that right, Peter? You agree? Now, I want to go back to my operation, because this is what I think I want to know about this innovation. I want all the patients who have it. I want the procedure details. I want the early outcome. I want any adverse event. I want long-term, actually lifelong follow-up. Value equals outcome divided by cost, but over the life of the patient, not over the next 10 days. And I need to know something about cost for cost benefit. I'm not going to get into how we calculate or measure that. It's not beyond our wit, as we've heard for the last few days, to develop ways that we can collect those data. But what I haven't heard in all of the last few days, is the next phase of this, is where those data go. Because I don't think that it is right that those data are held by the doctor or the submitter, or indeed by the journal. I think we need somewhere else where data can sit as an honest broker. Because otherwise, how are we going to get the transparency that everybody talks about? How can the regulators see the data? How can the employers see that? I mean, we just talked about whether we got is your institutional regulation correct? Why can't you analyze my data and improve the analysis that I thought of, which may well have been rubbish because I wasn't very good at sums at school? And why can't the patients see this stuff? They have given their data. Now, I've never met, not once yet, in all my working career, have I met a patient who is not willing to give their data altruistically to a good cause, like a blood donation, blood transfusion. The only time they get cross is if you nick their data without asking them, or sell it on to somebody else. So build rules around that. The honest broker can hold the data. The question here is who owns the data? I haven't heard it mentioned. But I believe our moral responsibility is to make the data available. Okay, so I come from a long-standing left-wing tradition of working in the health service, so I'm going to get a bit Stalinist. No surgeon should be allowed to carry out a new procedure without contracting to submit a validated data set through IDEAL or something else to the honest broker. Right. And that includes the second wave of surgeons. So if Peter decides to copy the Elliott operation, he shouldn't be allowed to do it unless he also signs that contract. Because otherwise, where are those patient data going to be? There's room for iteration along that process. The IDEAL model fits in. I'm getting even more Stalinist now, so if the parent reps are still here, I prepare myself to be shot down. I don't think patients should be allowed to have that innovation procedure unless they also agree to have their data go to the same place. Because we know nothing about whether that new operation is any good or not. So the moral contract with them is to say, look, I haven't got a clue whether this is a good idea or not. Might be able to tell you in a few years' time. Give me your data. We're going to anonymize it, look after it, make sure it's safe. At least the honest broker is. Our peers do this much better than we do. You know, if you're an astrophysicist, a mathematician, a statistician, a geologist, you cannot publish a paper without the raw data. Why in medicine are we even allowed to get near to publishing a paper without raw data? What can possibly be right about that? I looked at the NIH Library of Medicine to find out data sharing repositories, of which there are some, largely in the genomics framework and some in the cytokine network and some in other branches of immunology. There's no surgery. No data repository for what we do. That's why I feel shame. It's all about the data. What I propose to finish on is to say to you that I think the current system for publishing surgical innovation, not so much for how we design the studies, which you guys are doing a beautiful job on, but what we've got is a system that conspires against the proper accumulation of the data, certainly conspires against sharing it and analyzing it retrospectively or prospectively, and in my experience, my personal experience, facilitates fraud. The journals have published lies. Surgeons write lies shamelessly. Not all of them, of course, just the young male ones. This has created a set of perverse incentives. It matters to me that I build a large pile of papers. I think for those of you in the senior branches of surgery now, we need to find a better way to facilitate career progression. Think of the people involved in the CERN project, for example. Their success isn't based on the number of papers that they publish, but the quality of data and the quality of the collaboration that they're involved with. They publish separate papers which involve the 8,000 authors. There's a separate publication. The quality of data and their ability to collaborate is what's important. What we heard about today of the collaboration of young physicians through the Global Surgery Network is an astonishing exercise in exactly this. That collaboration is taking months, years to sort out. You'll end up with one paper about skin prep, and gradually you're going to shift the way our specialty works. This is important. I do not believe that our patients, these are my patients, must suffer from medical concealment, which I think that we are guilty of. And that's where I'm going to finish. Thank you very much indeed.